Welcome back to Africa This Morning. We are now on Table Talk, and today we're going to be discussing oral health. And we have two doctors in-house who are ready to give us tips on what habits we need to be adopting when we need to consider better health practices, especially when we're looking at our teeth and our mouth. Joining us in studio is Dr. Alwalia and Dr. Wetende. Thank you so much for joining us.
Thank you.
I'll give you an opportunity to expand what that doctor will entail for the conversation right here.
Thank you, Carol. My name is Dr. Wetende and Dr, as you've heard. I'm the chairman of the Kenya Dental Association. I also teach. I'm a lecturer at the University of Nairobi, Department of Periodontology, which just means gums. I'm also a specialist, the oral health sector, as a gum specialist.
Yes.
Yeah, thank you.
Welcome. Dr. Alwalia.
I'm Dr. Kavita Alwalia. I'm an associate professor at Columbia University in New York City. And I'm also the director of Global Oral Health Initiatives for Africa and South Asia, as well as the assistant director of our postdoctoral program in dental public health.
I'm glad I gave you the opportunity to highlight that, because I wouldn't capture it in one sentence. But when you're looking at the conversation of oral health, it's one that doesn't take the limelight very often. Maybe you can start with what realities we are faced with. We'll get to the African continent, but let's start with the Kenyan scenario. Where are we at?
The Kenyan scenario, the burden of disease is high. A recent survey conducted in Kenya, National Oral Health Survey, revealed that the prevalence of what we call cavities or dental caries is quite high, at 50%. That's 1 in every 2 children.
Yeah.
And worse still, when you come to the gum disease, it's about between 95 to 98%, which is literally affecting all our children.
Yeah. And these are statistics that are just highlighting for the children population in the country.
This is the children section. If you come to the adults, it's not much difference. The gum disease was 95%. The decay was about 40%. So let's say our population is really burdened with those 2 prevalent conditions. But we have other conditions which also affect the mouth, which we shall be shedding light on. Examples are oral cancer, we have malformations of the face and the oral region. We have other problems afflicting the head and neck area. But those 2 conditions are quite prevalent that we have to start talking about them loudly. Yes.
Yeah. On the African continent, is it the same scenario disaggregated by regions?
The scenario varies. So for instance, in Ethiopia, the prevalence of disease is very low, in fact. So it varies by country. I think it varies by access to tobacco, processed foods, things like that. But I did want to add to what Dr. Wetende said. The issue is not just around the amount of disease. The issue is what happens when you have the disease and it goes untreated. The consequences of untreated oral disease are really very profound. If you think about it, you need your mouth to talk, to smile, to kiss, to sing, to scream,
to eat,
to socialize, to be who you are. And if you can't do that, your quality of life is really, really low. I'll just give you an example. I am from Kenya and very excited to be here and doing this work and being able to give back to my country. I was here in June to work with Dr. Wetende and other partners, and my parents employ a driver, and he had some toothache, and so we managed to send him to the dentist, and the teeth were extracted. So I came back last week, and I went to see him, and he had covered his face, and he wouldn't really talk to me because they had extracted 4 front teeth but hadn't replaced them. So he was extremely embarrassed to talk to me. He didn't want me to see him like that. This is not acceptable, right? And I think that's what happens a lot in Kenya. We extract the teeth and then we do nothing.
We'll expand a little bit more about the relationship and the discipline and professionalism that is present, especially in the dentistry society and the professionals therein. We'll have you respond to that. But when you're looking at the scenario of being conscious about our dental health care, you mentioned when you have the condition, but are we very knowledgeable about what the moments that will get us to that point we actually are in the circumference of dental conditions that can lead to, one, life-threatening scenarios and also uncomfortable interactions with society?
I think, so Dr. Wetende has just mentioned that, you know, we finally have a national oral health survey. We hadn't had these data for a very long time. So now we're ready to package the data correctly and to really understand them and begin to provide the evidence that policymakers need to move the agenda forward. So we've really made huge strides. However, I think the data on some of these things, what does the public know, how much more do we need to do, how much oral health literacy is there in the country, those data are lacking, and that's where the work begins now.
Dr. Wetende, is that the opportunity that is allowing for some questionable professionals in the dentistry area to take advantage of an ignorant population?
Yes, I would say yes, because once you have a large population which has reached the treatment phase, and the numbers of dentists are not a lot, according to the Ministry of Health, the ratio is 1 to 40,000. Of course,
which is not manageable.
Yeah. The ratio by itself doesn't mean much, but once you reach the curative phase, then significant. With such a burden of disease and such patients reaching, then we have people who are trained in other fields coming to dentistry and outright quacks coming to do curative services. And the problem is that it's a specialized area. And so some of the technical expertise, like replacing of the teeth, requires some more technicality than removing the teeth. So you'll find many people have had the extraction, but the expertise of replacement is not there. Again, cost becomes a limiting factor. The extraction, because it's being conducted by, let's say, not very experienced people, will charge less. But when it comes to replacement, when you have to go now to the specialist, the cost will be prohibitive. And so you'll find, in dentistry term, half treatment. Of course, they have relieved pain, the person is better and functioning, but they have not completed the picture of treatment. So in my view, we should deal with the preventive arm more, so that we don't have more people reaching the curative phase. In that case, the ratio of 1 to 40,000 will just be a textbook thing. So once you prevent the disease, you have less people requiring treatment. So the numbers, because as you know, training a dental surgeon in this country takes 5 years. To specialize in one of the specialty areas between 3 to 5 years. So that's 8 years to
that's
have
10 years if we round it off.
Yes, to get a specialist out in the market. And of course, the other way to look at it is to train other cadres who will come in and really handle the preventive arm aspect to enhance what she's talking about, the literacy of our general public. Yep.
When you're looking at general public literacy, at this point, the conversation is heading us to the point of prevention. Is that only a responsibility that the clientele, the population can take up, or is it a multi-sectoral campaign?
It's a multi-sectoral conversation that needs to happen. You know, I think as dentists, we're always taught to tell our patients, brush your teeth, and we get upset with them when they don't. But a lot of times we don't understand the challenges that they have to doing that. So I live and practice in the United States, and I think everybody feels that, you know, even in the US, everyone brushes, and that's not true. People don't have sinks, so they can't brush. People don't have water, and that's really a problem in Kenya. Also, the cost for receiving dental services can be prohibitive, but for many people the cost to buying a toothbrush and toothpaste can also be difficult. So we really need manufacturers, we need government, you know, to sort of make policy around this and help people buy the tools that they need.
Right from the entry point of dental oral health care.
Right. Yeah, that's right. We need people in the agriculture industry and food industry, you know, lands and water and everybody to really come together and tackle this together.
There's a conference that was conducted just to showcase the reality that we're faced with as a nation oral health care. Share with us what the summit was intent on doing, what the summit is hoping to achieve, especially when it comes to bringing all the sector players on the table and having them have a conversation about how to be more conscious about oral health care.
I'll deal with the theme and let my colleague Dr. Kavita deal with the nitty-gritties of the summit. The theme really talked about integrating oral health to general health. As you all know, oral health is really neglected, so to speak, in terms of general health. First of all, in terms of budgeting, is neglected. Worse still, the small money which comes to health now, oral health is further neglected.
So we're barely achieving their budget declaration of having 15% allocated to health. What exactly is directed to dental health care?
As we speak, the last budget, it was 0.006% of the health budget, and the health budget, I think, was about 5%. So it's, in figures, it's about 380,000 Kenya shillings.
For 42 million people.
Yeah.
That's right.
Yeah. So it's crazy. So,
like sorry to say
that.
Yeah.
But anyway, I was expounding on the theme. So oral health, most people want to look at it in isolation. But as you've heard, oral health condition, as Dr. Kavita has explained properly, you have pain, anxiety, low self-esteem, you'll miss work. If your child doesn't go to school because of pain, you also not come to work because you'll have to go and pick your child and attend to them. And apart from that, the causes of oral diseases, as she has enumerated: unhealthy diet, consumption of alcohol, use of tobacco, either smoking or in our setup we have the mbake, or the tobacco used directly, chewing.
Tobacco,
So those causes, apart from causing oral diseases, also cause other diseases in the body. Unhealthy diet, for example, will lead you to diabetes, heart diseases, stroke. Alcohol and tobacco use will predispose not only to oral cancer, other cancers in the mouth, liver cirrhosis, and all that. So they have a common risk factor. So if we tackle the problem of common risk factor, we not only help the oral health, we'll help the general health in common. Also, another link is that oral diseases have now been shown to cause other ailments in the body. Direct link with from gum disease to diabetes, either causing you to not respond very well to medication of diabetes. Another problem is that medications given for hypertension have been shown to cause gum to grow, or what we call gingival overgrowth, and you have a direct link. And so it is time that we stop looking at the mouth in isolation. That was the key essence of what we were deliberating in the summit. I'll ask Kavita to now
expand
come in.
on the grander scale of the
So
summit.
Columbia University took a leading role here in bringing who we considered to be all the stakeholders in this conversation. There was one stakeholder that wasn't necessarily at the table, and that was the community. And now our role is to start working with the community to understand their needs and challenges more carefully.
We'll expand a little bit more about how we are going to be positioning that conversation to the
Yes, we
community.
will. But as Dr. Wetende has said, you know, we are realizing that the mouth can, you know, diseases of the mouth have common risk factors with diseases in other parts of the body, and in fact are associated with those conditions. As he mentioned, diabetes can be exacerbated by gum disease and so on. So we really need everyone in the healthcare community to come together. So when you go to see your doctor, they shouldn't be looking in your mouth and looking behind the mouth at the pharynx, but looking in your mouth. If you're diabetic, somebody should be checking your mouth to make sure you don't have gum disease so the diabetes can be controlled. So the intent of the summit was really to help people understand that the mouth matters. It's very important to everything. It's important to your health, it's important to your mental health, it's important to your social health. And so therefore, as a society, we need to start addressing it, and we need everybody to address it. And you know, I keep going back to private sector, but they need to understand too that the mouth is important and that they need to join with us and partner with us to help us get to the people and let them know.
What was the feedback and how enthusiastic were private sector stakeholders in including this as part of their conversation, especially when it comes to product development, service delivery as well?
I think they are. I think they're very enthusiastic. Unilever helped support this summit. But they're a dental product manufacturer, so obviously they have a stake in this. But we are trying to engage other private sector stakeholders and hope that they will come to the table soon.
Getting the
Let me comment on service delivery on the government side.
Okay.
Something is being done. We're not saying that nothing is being done. Kenyatta National Hospital, we have a waiver system now for the very needy cases. And the only drawback is that the system is lengthy. You all know our presentation is normally late and people are in pain. So if you are taken around a whole day for you to come tomorrow and you're in pain, then it doesn't work very well. The University of Nairobi Dental School also has subsidized dental services, and they're cheaper, and so people can access that.
The provision has always been there. What are we doing to ensure that there's faster service delivery so that you can be able to see impact as quick as possible? I know that's a question that's a little bit pressing at this point. Yeah, considering
of course
the
there's
number
constraints
of dentists
because the school is limited to the number of students.
Yeah.
So there's no way they can open it up. They'll be overrun.
Yeah.
Because the students are the ones who run the clinics. Yeah, but I was going to come and say also the other arm is that NHIF has now accepted to cover dental problems, which is a good step. It's a beginning. Of course, the amounts are still low, but we lobby for more money to be allocated to the dental sector. Because what we are dealing with now is the dental caries, the rampant caries. People are in the pain stage, so we need to mop up that fast, and that's costly before now we come to the stable patients. Yeah, so something is being done. It might not be enough, but it's a step towards
the conversation.
That. As Dr. Kavita says, once we push the advocacy and include other partners, we'll come to support these small initiatives, then we can go a long way.
I like the statement that Dr. Kavita has just said, the mouth matters. How can we get the conversation to the public to understand that as much as, yes, it's your personal responsibility to be very conscious about your oral health, that you have to understand that it also impacts on the community around you and how you are effective in society? What is my responsibility as an individual?
Well, so I just have to go back to the service delivery because while we have some initiatives in Nairobi, you have to recognize that this is a country of 42 million people and there's not much happening at the district level, and now health has been devolved to the district counties. So that's where we have to go. We have to reach everybody. And yesterday at the summit we heard about counties where they've placed a dentist but there is no dental chair. That's not acceptable. These things have to change. And so when I'm talking private sector, equipment has, someone has to come forth with equipment, or we've got to have indigenous entrepreneurs develop equipment that can be sourced cheaply and that's relevant to this country.
Is that a conversation that is enthusiastically being adopted, considering that even at the county level, financial allocation to the health sector right at the county level is very minimal? Will we have dentistry taking a priority?
We've started this conversation over the last 2 days. We've had the medical directors from the counties at the table there, and Columbia is going to start a demonstration project this summer in Kitui County. So I think you have to do everything systematically. You have to develop the evidence that's needed to then inform policy, and I think once you start and you bring other people to the table, it can happen. But it has to grow and it has to happen quickly. I think not just in Kenya, in every country, even in the United States, oral health is always given a short change. But I think now we're at the tip of the iceberg. We recognize that it really does matter. It's important. And I think in answer to your question, it's how we package it. And that responsibility rests with the dental community. We need to let people know what the risks are, what happens if the disease goes untreated, and how to manage it. That's our responsibility, and we need to take ownership of that.
Yeah. Let's
So I'll jump to your question. What is your role?
Yeah.
Yeah. Apart from healthy diet, avoid alcohol, or quit altogether, and smoking. You also have the role of hygiene.
So at this point, I can officially say that we can't demonize particular foods when it comes to oral health care.
Yes, oral health, the sugary foods, carbohydrates, are the main culprit of disease, because what happens is that the bacteria in the mouth will convert the carbohydrates into acidic, what we call plaque, and that has
erode the enamel of the tooth,
and also cause inflammation of the gums, which lead to gum disease and further destroy the supporting structure of the teeth, and then they fall out.
They indicate that they are cheat systems. You can take a sweet but brush immediately. 5 seconds later, you can drink, a soda, and then you can brush 5 minutes later. Is that something that
Of course,
is an
the
option?
pyramid of the disease has time element into it. And the time element mainly is how long, because something to cause an effect has to be there for some time.
Yeah.
And brushing mitigates that to some extent, or removing the plaque to some extent. But as we've said, the diet doesn't only affect the mouth. You'll end up with obesity, diabetes, and other conditions. So it's best to modify your diet if possible. Because it's not only the mouth. Of course, in the mouth, we mitigate by brushing. And that's what I was talking about, hygiene. We advocate that you brush your teeth twice a day, day and night, with a toothbrush, if possible with a toothpaste. If these are not available, then muswaki at least
Can
will
help.
mitigate, yes, because as long as you are sweeping off the bacteria before the acidic change, then you get some sort of protection in the mouth.
So there's no excuse at this point.
There isn't, Beryl. I mean, even if you don't have muswaki, you can use a washcloth, a small towel. You can rinse your mouth out with water. I don't want to demonize any food. Everything in moderation, right? But I do want to point out that if you have lost your teeth, it's not really easy to eat a good diet because you won't be able to bite fruits and vegetables. So what happens is that people start eating very starchy and sugary foods, white breads, pastas, ugali, soft food. So it makes a bad situation worse. It's
a vicious cycle.
It's a circle. You need your teeth to be healthy. I keep coming back. It matters. So it just doesn't matter to have that healthy diet for your mouth, but for diabetes prevention, for heart disease prevention, for all the things that middle and high income countries face today. All these chronic diseases. I think also. We tend to think of dental diseases as being non-communicable, but dental caries is caused by a bacteria and so is in fact infectious. And mothers often pass it on to their children. I don't know, but I see it all the time in the restaurants. A baby is eating, the mother is feeding with the spoon and then puts the spoon in her own mouth. Those kinds of things.
We need to be a little bit more conscious about what we're
don't
doing.
use the same cutlery as your children. Don't use the same glasses because you will infect them. Children are born without the bacteria that cause dental caries. It's moms and other people in the family that infect them.
That's very important to actually note because we are always looking at it as an opportunity for affection, but it's not. We're literally in a situation where we are infecting our children with very serious conditions.
That's right.
Conditions.
That's right. In fact, I live in the U.S. and my daughter has an American grandmother who would always kiss her on her mouth when she was a baby, and it used to make me completely crazy.
So what do you do in that scenario?
Wash her mouth immediately.
These are personal choices that we need to make. At this point, when you're looking at, one, we've started the conversation on a national front with a summit already presenting an opportunity for the country to be conscious about oral health and prioritize it, especially when it comes to financial allocations. What were the highlights as an introductory conversation on oral health? What were the highlights following the summit?
Well, I think, it's clear. The need is very high and it's growing. Kenya is poised in terms of development and economy and so on. However, the public funding for many of the things that are needed has not followed suit, and especially in oral health. As Dr. Wetende mentioned, the national budget is somewhere around 380,000 shillings. So how do you, where do you go from there? I think the districts, counties, have, a little bit more jurisdiction, and so in my mind, perhaps that's where we go as well. We need to bring them all to the table. But something has to change. We can't just keep going on like this. We really have to recognize that the mouth matters, and if you neglect it, it's going to affect everything else.
Dr. Wetende, from your perspective?
Our highlight was that we know the problem. We've been talking to ourselves, so we need to package ourselves properly so that we can advocate, so that other people can come in to assist us to inform the public and to also invest in the curative arm of dentistry. So advocacy, for me, came out very strongly that we need to package ourselves properly. We have been too scientific and too technical.
Within a cocoon,
yes, we're staying within our cocoon with our technical terms, that we scared everybody away. And we lost the message to the public. We lost the simple, effective ways of preventing and promoting oral health. So that came out clearly that we need to refocus and we need to knock doors. We need to knock doors. You'll be surprised that even the traffic department, we need to knock doors. You'll ask why. You've seen the border people riding without people, they have no helmets. Once the children fall, the first injury, or the adult, in the head and neck area. That is in the oral and maxillofacial area, that's a dental jurisdiction. We see those patients first. So we need to knock doors and advocate that people, the traffic rules which are there should be enforced. Those things as a package were well articulated, that we need to go back, package ourselves simply, and come out to inform the public and to champion for some funds to go into dentistry or oral health in general.
What are some of the areas, one on the global front, that we can borrow from in terms of best practices and being conscious about allocation to oral health care? Even as a nation, we're going to seek best practices that we can be able to customize on the local front.
I think that we need to be very careful about borrowing from other people, because we have to make sure that the solutions for Kenya are relevant to Kenya and arise from Kenya. Kenya has unique needs, unique resources, unique political structures. So I caution, just borrowing. We really need to introspect and carefully look at the data and carefully collect other data that might be needed, and make decisions for ourselves. And they have to arise here. I work for Columbia University, but I am Kenyan, and people ask me, what is the role of Columbia University? Our role is to facilitate and to help, but the doing has to happen here.
At this point, Dr. Wetende, what are some of the unique opportunities that we can take up so that we can be able to create Kenyan solutions for Kenyan problems when it comes to oral health care?
Of course, we have some data, but we need to go out there and get more data so that once you get a solution, you tailor it to where our biggest problem is. So far, we know our biggest problem is dental caries and periodontal disease, which are preventable. So the preventable arm, we are articulating it currently on the table, and that was the peak of the Oral Health Summit. We also know that we have problems with oral cancer, which is on the increase, and now we need advocacy to that effect and knock doors that simply creating smoking zones doesn't seem to be working. There seems to be maybe more, because maybe you go there and you can be given a cigarette if you didn't have, as opposed to when people are walking, nobody would stop to talk to you when you ask for a cigarette. Maybe there are some things we need to tailor more. So In terms of the Dental Association, the Kenya Dental Association, we have been trying over years to create awareness, to try in a small way to intervene where possible. But it seems to be a small drop in the ocean.
Yeah.
So we need other players to come in, to partner with us, to support us, and to help us to reach out. Because some of the areas don't have television, don't have radio. So you have to physically be there.
Present.
Yes, teaching. In fact, I saw a clip of somebody who was dealing with eye problems in northern Kapenguria, and was very touched and said, we need to follow suit. Physically present, you have a tooth problem, talk to the villagers, educate them, and move on. The other thing which is coming out is the water issue. The water issue, we need, there seems to be a lot of boreholes which are coming up, especially, initially the dental fluorosis problem was in the areas in the Rift Valley, Nakuru, Murang'a. We used to get the problem of dental fluorosis, but currently we're experiencing people in Nairobi and the environs having dental fluorosis because of borehole water which is being used, which has very high fluoride. And see, the law is there on those matters that a certain fluoride level should not be exceeded. Why it is not being enforced is what we need to be asking in our setup. Again, in our setup, there are areas where, as she has mentioned in passing, that people have no water. We know that from the clips we see in the TV that some areas the goats and camels are drinking, and the same water the children are drinking. And they have walked, I think, a whole day to get to that spot. You can imagine going there and saying, brush every day. So will they wake up and walk 10 miles to go and brush and then come back? So those are some of the issues locally we need to address. Those are our unique problems which might not be there. The United States probably have piped water for everybody. And those are the kind of solutions. Even boreholes, there are many NGOs going around sinking boreholes. It's a good thing. At least people have water. But how safe is that water? There needs to be a follow-up. How safe is that water? Is it supposed to be for animal consumption? Is it fit for human consumption? There has to be a distinction. You can't just come because it's water and I've seen water, I drink it, and next time the whole community has a problem.
The conversation is is hanging very heavily to the county's level.
Yes.
But you see, Dr. Wetende just gave you a key example. NGOs come in, they drill the boreholes, but they're not talking to the dentists. And the dentists are not talking to the NGOs. You need to work together so that when they do put a borehole, the dental community will test the water, you'll know what the fluoride is, and you can advise the population or find a way to defluorinate it. But we need everybody to work together in the, the areas that Dr. Wetende mentioned, where the eye camps go on and so on. It's completely feasible that somebody who's looking at your eyes can look in your mouth if we train them to, because they're not very far away.
At least it's something that we can work on as a nation. Even as we end the conversation, we have already conducted the summit. What next? Where is the first step? How often can the summit be conducted, if it's going to be often? And looking at the relationship between government and the private sector, public-private partnership, so that you can maximize the conversation, not only as a one-off summit, but a conversation that will be conducted often.
Well, Columbia University is here and we're here to stay. We are designing with the University of Nairobi a demonstration project both here in Nairobi and in Kitui. In Nairobi it will be an experiment to see whether level 1, 2 and 3 workers can be trained to address oral health needs among very disadvantaged people living in poverty-stricken areas, in urban areas. In Kitui will be more around trying to understand the structure and where in the structure we can integrate oral health. So who, do we want to talk directly to the people? Do we want to do it in schools? Do we want to do it with level 1, 2 and 3 workers? Because they're, and so we're going to have a comparison between rural and urban. And then we hope that we can inform policy in that way. But we will continue to bring the players together. We will continue to foster partnerships because, like I said, the work has to be done here and it has to be done by Kenyans. We also feel very strongly about building capacity. So we're in discussions around, I think the Kenyan workforce, the dentists, physicians are incredibly well-trained clinicians. But I think, you know, as Dr. Wetende said, helping package the message differently, framing the message differently is something that we can help with. So we want to start building capacity so that Kenyans themselves can do this and
on
their own, so that once you have the capacity and you have the infrastructure, then you can build solutions that are sustainable. You don't want to have other people to come out and do it for you, because once they leave, everything stops.
Dr. Wetende.
For us at Kenya Dental Association, what we shall do is pick up the proceedings, come up with a strong paper. And from that strong paper, of course, we had all the stakeholders there. We had lucky to have ears of the cabinet secretaries around there. And so from there, we shall proceed to fill in the gaps of the oral health summit, the local data, the local findings, and use it to advocate the preventive arm of dentistry and the curative arm lobby to have more equipment, more materials, more resource, certain cadres of human resource trained to address this, let me call it epidemic of oral health disease.
When you're looking at the habits that we need to adopt, we've mentioned a lot, but how often do I need to be visiting my dentist with my issue of dental phobia issues? How often do I need to be visiting one dentist to see
Scary to you.
to see how my teeth are doing?
Dental phobia, let me just speak little about it. It's propagated by such a statement in the media.
Yes.
Yes.
I am sorry.
And then, and then two, mother to child or parent to child. Those are the kind of stories we want not propagated at all.
Where do I need to research so that I can get credible dentists who can, one, take care of my oral health, and I can be able to access them? How often I can be able to
Let me
see them?
start with your first one.
Yeah.
It's recommended twice a year, but locally we say at least once a year we'll be happy. At least we'll get some income from you. Yes, but to get the data of the dentists who are practicing, there's a website by the Kenya Dental Association which you can log in, and the name of the practitioner will come. But the legal one is in the Medical Practitioner Dentist Board. It will show you the doctor's name, his status, whether he's active, his number, his registration number, and where he's practicing. So that will avoid you from going to the quacks. At least they have started, I think they have an SMS number which they were testing, but has not come into effect. Once that is in effect, be able to say Wetende and verify whether.
That's powerful.
Yes.
Yeah, technology is playing its part when it comes to sensitizing the population.
Well, Beryl, I just want to say two things. You know, I think the whole idea that dentistry is painful comes from olden times when dentistry was practiced without anesthesia.
Okay, that's
and
true.
with equipment that, you know, shook your mouth, your whole head, your whole body, and was painful. We've come a long way from that, and much of dentistry is painless. And I also want to say, if you don't go and you don't take care of those teeth, the pain that you're going to experience is going to be times 1 million. You know, when I was a resident, I had to extract this woman's teeth, and she said to me that the pain she experienced was far worse than childbirth, and she had 4 children. So it really is profound pain.
Yeah, it tells you.
Yeah,
and we don't want to get ourselves to that point where we have our teeth extracted. We want to prevent that as much as possible.
And you don't want to be in that kind of pain either. It's not worth it, because this is a very easily preventable disease. It's not a disease, you know, your mouth is so easy to access. I can look very quickly in your mouth and tell you that something's wrong and that you need to take care of it, unlike, say, heart disease, where we have to do invasive procedures. So this is very easy.
Thank you so much.
And I was going to finish by saying when, because most mothers ask, when do you start cleaning the baby's teeth? When do you come for the first checkup? As soon as the first 2 teeth are wrapped, which mostly are the lower incisors, start cleaning the teeth with a soft cloth or with a clean, wash your hands with your finger, just to remove the debris. And as you had here, milk.
And you clean the tongue as well.
Yes.
That comes later. But clean the mouth, as the gum pads. And as you've had, milk also has some sugar. And worse still, if some people add sugar to that milk, especially when they are bottle feeding. So bottle feeding is also another area that I think we out of time, so we will not go there, which predisposes the young people to get the dental caries, especially if left overnight with the bottle in the mouth. We recommend about 2 to 3 years. You need to start bringing your child for checkups so that if there is anything, especially teething patterns and all that, the dentist can advise, or the oral health care provider who is at the place can advise whether the teething is going on well, whether there are other problems. And of course, to avoid myths, at 6 months, the children are having their first teeth in, but also at the same time, the immunity of the child is moving from the mother's immunity to their own immunity. At the same time, the children are feeling things with their mouth. So the diarrhea and fever is not associated with teeth. That myth has really brought problems in our local setup, where people go and now remove the toothbuds of teeth, saying that it's what causes diarrhea and vomiting and fever. So that is not at all related to the teeth. That message should go out clearly.
Thank you so much for joining us, Dr. Luali and Dr. Wetende, giving us more information on oral health care. And as a population, we've given you a roundup of what you need to be doing, what you need to be keen on, and how you need to be sensitized or sensitize your population and even your family when it comes to oral health care. Of course, there'll be more information on the same on our online platforms. From the team and myself, enjoy the rest of your viewing, and I'd like to wish you a great Easter holiday. We'll catch up with you next week.